Gastroesophageal reflux disease, also called GERD or acid reflux, occurs when the stomach contents back up into the esophagus, at the lower end of the esophagus. This is where it connects to the stomach. There is a circular ring of muscle called the lower esophageal sphincter. After you swallow, the lower esophageal sphincter relaxes and opens to allow food to enter into your stomach. The lower esophageal sphincter then contracts, shuts to prevent the food and acid from backing up into your esophagus. The action of the lower esophageal sphincter is normally assisted by the muscle of the diaphragm, which surrounds the lower esophageal sphincter. However, sometimes the anti-reflux barrier comprised of the lower esophageal sphincter and the surrounding diaphragm fail, allowing liquids and stomach contents to wash back up into the esophagus. Who gets gastroesophageal reflux disease? Hiatal hernia is a condition in which part of the upper stomach pushes up through the diaphragm, positioning the lower esophageal sphincter in the chest. The diaphragm has an opening for the esophagus to pass through before it joins with the stomach, called the diaphragmatic hiatus. In people with a hiatal hernia, the hiatus becomes dilated and part of the stomach will squeeze up through this opening, and this is called a hiatal hernia. As a result, the diaphragm no longer helps the function of the lower esophageal sphincter, and acid reflux becomes more prominent. Obesity, pregnancy, and some foods, such as fatty and spicy foods, chocolate and peppermint, caffeine, alcohol, and cigarette smoking also contribute. What symptoms will we experience with gastroesophageal reflux disease? Heartburn, which is a burning sensation in the center of the chest, which sometimes spreads to the throat. Regurgitation, this is when stomach contents flow back into your mouth or the back of your throat. Upper belly pain or chest pain, difficulty swallowing, where food gets stuck in the esophagus, or pain upon swallowing, hoarse voice, persistent sore throat, or cough sensation or lump sensation in the back of your throat. With long-standing GERD, you may also get erosive esophagitis, and this is when the esophageal lining is damaged as a result of exposure to the stomach acid. This can lead to erosions or ulcers, which may bleed. Barrett's esophagus. Barrett's esophagus occurs when the normal cells that line the lower esophagus are replaced by different cell types. This process usually forms from long-standing GERD with erosive esophagitis. Barrett's esophagus has a small risk of transforming into cancer cells over time. Esophageal stricture is another complication from damage from acid, can cause the esophagus to scar and narrow, causing a partial blockage or stricture that can cause food or pills to get stuck in the esophagus. You also may experience dental problems, with the repeated exposure of acid reflux can erode the teeth over time. How do we diagnose GERD? Based on symptoms, if you have the classic symptoms of GERD, which is heartburn and or regurgitation, this situation, a trial of a PPI medication is indicated. If your symptoms improve, it is likely that GERD was the cause. Additional testing is required if you do not have improvement in your symptoms after taking the proton pump inhibitor or the PPI, do not have the classic symptoms of GERD of heartburn or regurgitation, have symptoms that may indicate another problem. Now for this, we would go to an upper endoscopy. It's a test that allows us to visualize the upper GI tract. A small flexible tube is passed through the mouth into the esophagus and into the stomach and small intestine. The tube has a light source and a camera that displays magnified images on a monitor. With severe reflux, there can be ulceration of the lining of the esophagus called esophagitis. Damage to the lining of the GI tract can be evaluated and samples of tissues or biopsies can be taken to determine the nature and extent of tissue damage. An esophageal pH study is the most direct way to measure the severity of acid reflux. The test involves inserting a thin tube with a sensor through the nose and into the esophagus, which is left in place for 24 hours. The sensor measures how often stomach acid reaches your lower esophagus and how long it persists in the esophagus. Esophageal manometry involves having a tube placed through your nose into your esophagus that measures the pressure from the muscle contractions. This can help determine if the esophagus and the lower esophageal sphincter are functioning normally. How do we treat GERD? We start with lifestyle changes, losing weight if you are overweight, raising the head of your bed or sleep on your left side, avoiding foods that trigger symptoms such as caffeine, chocolate, alcohol, peppermint, fatty, and spicy foods, quitting smoking, because smoking the saliva helps to neutralize the reflux acid, and smoking reduces the amount of the saliva in the mouth and throat. Smoking also lowers the pressure in the lower esophageal sphincter and provokes coughing, causing frequent episodes of acid reflux in the esophagus. Also, avoiding late night meals, lying down with a full stomach may increase the risk of acid reflux. By planning the meals for at least 2 or 3 hours before bedtime, symptoms may be reduced. And also wearing loose, comfortable clothing may also help, because at a minimum, fitting clothing can increase discomfort, but it also may increase pressure in the abdomen, promoting the hiatus hernia and forcing the stomach contents of into the esophagus. In addition to lifestyle changes, the initial treatment of mild GERD include the use of non-prescription antacids or histamine receptor antagonists. Antacids, such as Tums, neutralize the stomach acid and are commonly used for short-term relief of heartburn symptoms. Histamine antagonists, also called H2 blockers, reduce production of acid in the stomach. They are more effective than antacids in relieving the heartburn, and their effects last for longer. Proton pump inhibitors, or PPIs, are more effective than H2 blockers for reducing stomach acid, but long-term risks of PPIs may include increased risk of certain gut infections, reduced absorption of minerals and nutrients, and generally these risks are quite small. However, even a small risk emphasizes the need to take the lowest effective dose for the shortest possible time. Some people do not experience complete symptom resolution with PPI treatment. This is referred to as refractory GERD. If you continue to have bothersome symptoms after a course of PPI treatment, your provider may recommend one or more of the following: splitting the dose of PPI, increasing the dose of the PPI, or switching to a different, more potent PPI, and also considering surgical treatment. Surgical treatment may be an option for certain people whose symptoms are not adequately controlled with other treatments, or who cannot or do not wish to comply with a medication regimen. In general, anti-reflux surgery involves repairing a hiatal hernia, if present, and strengthening the lower esophageal sphincter. The most common surgical procedure is called a laparoscopic toupee fundoplication. The procedure is completed minimally invasively, typically with 5 small incisions. This procedure involves wrapping the upper part of the stomach around the lower end of the esophagus. Complications include difficulty swallowing, feeling bloated, it's called gas-bloat syndrome. These symptoms may resolve over time, but can persist. Recurrence in about 10%, and 2% will get lung infection, blood clot, heart complications, or a leak. Most people, however, say they are very satisfied with the results of the surgery in the long term.